Welcome to Optimized Health Podcast. This is the first one of 2025.
It's exciting.
I'm super excited.
Yeah.
So this is really technically, I'm in my Valley Girl face. This is technically our, third season?
Third season. Yes.
That is
It goes by fast, doesn't it?
It does. I feel like my body said, dude, yeah, we're in warp overdrive.
Yeah. Yeah. What day is it? What time is it?
Did the holidays screw you up?
Oh, for sure. Especially being midweek, I was like, Thursday felt like a Monday.
Yes.
And
like a legit Monday.
Right, I know.
It was weird.
We had too many Mondays in December.
Then you turned around and it was Friday and it was like, was that literally not the fastest week in,
And did we get a
history?
weekend? And
yeah.
I kind of liked the work one day off too, though. I got used to that schedule.
I'm not going to lie.
I know. I mean, that was kind of nice. I was like, I'm getting too used to this.
It was not terrible.
Yeah.
Do you have a resolution for the year?
I'm not huge on resolutions. I think
either.
intentions, like I heard someone say that the other day and I thought, that's really resonates with me because if I make a resolution, then I feel like it's just a checkbox.
Yeah.
But I really just want to continue the things that I've been working on and maybe take them up a notch. So that's kind of where
things have been going good.
Yeah.
So
I feel like I'm in a groove. Yeah. So let's just, continue on. Maybe like persistence, maybe?
Yeah.
Consistency. Maybe there's my resolution. Yeah. I'm not sure.
Yeah.
We'll see. Ask me in February.
We'll just manifest all the good.
Exactly.
We'll just keep that rolling. Yeah. Uh-huh. I have no doubt.
What about you, Mandy?
I don't have one.
No?
I don't have one. Now, sometimes I will do one, oh, I want to, I don't know, eat less carbs or something. I'm like, I want to eat more carbs, but I'm not allowed. But there's that. So that doesn't necessarily work in my favor.
No.
But no, I just feel like things have been going really good. So therefore, I just want to,
maybe momentum. Maybe there's your word for 2025. Just don't stop the momentum.
I can't. If I do, I'll get ran over by a man named Josh Porter. I feel certain.
Oh, goodness.
Oh, my gosh. Well, we've got a guest today.
We do. I'm super excited about this guest, a longtime friend and colleague of mine. We have Emily Brewer, nurse practitioner and owner of the Derm Center with us today.
Mm-hmm.
Emily,
I've been a patient of Miss Emily.
Same here.
No.
Emily's taking care of my whole family. So I think very highly of her and her expertise. And I call on her for questions and have sent many patients her way just because I trust her intuition and her expertise, and super excited to get to talk to her today and hear all about that.
That's exciting.
So welcome, Emily.
Thank you so much for having me.
Yes.
We're excited to have you. Listen, I've been like, let's talk to Miss Emily about, I got some questions.
I know. We may need to have a part 2 to this.
Seriously.
I mean, there's too many things we deal with as women. But today, right? I know. I mean, we have a lot of little annoyances, I guess, nuances, whatever you
I
want to
went
call
through
it.
all the ages, not just an adult life.
Exactly.
Right.
When I have a teenager,
Yeah.
I have to deal with those skin issues, my skin issues, those hair issues, my hair,
Yeah.
And so trying to be an expert when you're standing there in the grocery store aisle looking at all those face washes and
overwhelming.
acne treatments, and it is very overwhelming. It's like cold medicine.
It is.
Trying to pick a cold
That's
medicine
exactly
is
what it's
very
like.
difficult.
Yep.
I'm just trying to be Barbara O'Neill and roll out with some herbs and like olive oil or something and solve all the world's problems. That's what I'm trying to do.
If only it was that easy.
I know, right? But today we're going to focus on something that is just really difficult to treat sometimes and hard to diagnose. And we see it all the time in practice. And that would be issues around hair. Mm-hmm. And we see changes in hair. I think I saw a statistic this weekend that said over 50% of menopausal women will have hair loss. And so, in our world, we deal with a lot of perimenopause, menopause, but even young women, we're seeing more and more come in with hair loss. And so trying to treat that can be difficult for provider. It can be a little more of a complex issue.
Yeah.
And so we're going to pick Emily's brain today and see if she can teach us a little bit about hair loss.
Absolutely. It is definitely something that we see so much of in the office. And I think a lot of people will sort of classify it as a cosmetic issue when in reality, it's not at all. It's extremely stressful. It's extremely disheartening for patients that are struggling with their hair coming out. And it can be a challenge figuring out what's causing it and how do we get it to stop? Can we get it to stop? So hair loss is a lot of misconceptions too of it being a very simple, just my hair's coming out, how can we fix it? And it does take a lot of putting the pieces together to figure out what the underlying causes are and can it be corrected.
Yeah. And you know, the hair, I know the hair goes through cycles.
Yep.
So can you explain to us kind of like when you start to experience hair loss, what is that cycle like? It's not one thing that you treat and next week it's better.
Right.
You know, it kind of has to cycle through. Can you kind of explain how that works?
Yeah. So I definitely think starting first with, looking at a very thorough history with a patient, that's the first thing that we have to look at when a patient comes in complaining about hair loss. Because while there are cycles that can be seen, it can also be a very progressive, chronic, ongoing condition too. So the first thing that I like to do is get a really thorough history with a patient to see, what are the other issues that could be happening? Are they perimenopausal? Are they postpartum? Has there been a major life stressor? Family history of hair loss? Are there a lot of men and women in their families that struggle with their hair coming out? So there are a lot of variables in the history to look at. Is there an underlying autoimmune disease? That's also something really important to consider. So I like to start with a really thorough history with a patient, and then we sort of move into more of the workup. Lab work is a really common starting point with the majority of patients. And while hormones can certainly be a very common contributing factor, it's not always the only thing that could be causing the hair loss. So good thorough history, getting a good picture of their blood work, but then also too, biopsying the scalp can also be a very common part of the workup as well.
Would you do that only if there were and I'm not of the medical field, so I am your average Joe, so I'm going to use average Joe words, like a bald patch as opposed to having, man, this just feels a little bit thinner.
Yeah.
You know what I mean? Having something as dramatic as like a quarter size bald patch in your hair, is that along the same lines? Could those both mean the same thing?
Not typically.
Okay.
No. So a bald patch is actually one of the easier types of hair loss to treat. Yes.
I would think that would be harder.
It's usually very straightforward with what we're dealing with when a patient comes in with a very symmetrical, very smooth bald patch. Typically, that's more along the lines of alopecia areata, which can be a very autoimmune type of hair loss that we see. Oftentimes, we treat it with injectable steroids. There are other topicals that can be used for that type of hair loss. So that one is usually pretty straightforward. The more difficult cases are the patients that come in with just very generalized thinning of their hair. That would be an instance where a biopsy could certainly be warranted. The main point of the biopsy, though, would really be able to differentiate between, are we looking at a type of hair loss that's scarring, or are we looking at a type of hair loss that's non-scarring?
Okay.
Non-scarring hair loss would be something like alopecia areata. It would be something like androgenetic alopecia, which is the type of hair loss that we see in patients just as we age, and male pattern baldness, female pattern baldness, that type of hair loss. With non-scarring alopecia, basically there's a hair follicle that is still very present. It's intact. There's just not a hair shaft in it. The goal of treatment at that point is figuring out why is that the case and how can we stimulate hair to grow back. So that type of hair loss, that's a positive when we do a biopsy and we see that we're looking at a non-scarring form of hair loss. When we see scarring alopecia, typically that's going to be seen in more what we call frontal fibrosing alopecia, where scar formation takes over the follicle. When scar formation takes over the follicle is gone. There is no way to bring a hair back. When there's not a house for a hair to live in, the goal of treatment at that point becomes, how can we aggressively stop this from progressing? So the biopsy is more important in terms of differentiating between scarring versus non-scarring alopecia.
I want that on my legs and in my armpits.
We want it where we're going to get there.
We're going to get there, right? With the wanted and the unwanted hair that we deal with. As
I'm look, can you work its way down?
Yeah.
Right.
Exactly. I know. So would you say the gold standard would be a scalp biopsy to determine the actual type? If it's not a patchy bald, like if you're not seeing those bald patches, if it's more hair thinning, then a scalp biopsy would be kind of the gold standard for that?
Not necessarily. A lot of times the diagnosis can be made based on the history, based on the presentation, based on maybe some trial and error of other options for treatment first.
Okay.
I typically will move to a biopsy if I'm having a hard time differentiating between what kind of hair loss are we looking at, or certainly in a situation where we've explored treatments and we just can't see the results.
Like a failed option.
Exactly.
Yeah. So then when you look at that, what is the most common type that you see? Because I have my thoughts on what I hear most from my patients, but I kind of want to hear what you see in the derm world. What's the most common that you see?
I would say there are 3 types of alopecia that we see the most often. Number 1 would be androgenetic alopecia, the type of hair loss, the male pattern baldness, female pattern baldness. That's extremely common. Like you said, about 50% of patients, 50% of females experience that. So we do see that often. We see a lot of telogen effluvium.
That was what I was going to guess.
Yes.
And it's like
super common.
Is it more of a generic diagnosis like dermatitis would be, where you don't really know what the culprit is?
Not at all.
Okay.
No, it is a specific diagnosis.
Okay.
So telogen effluvium, it's extremely common to see this type of hair loss in patients post-viral. So since COVID happened, we have seen a ton of this type of hair loss.
Yeah, that's one of the symptoms.
Yes. So with post-COVID, we see a lot. We see a lot postpartum. Any kind of stress increase. So for patients that have a job change or they're going through a major change in their life, so a divorce or job changes, that type of situation is going to oftentimes be an increase in stress, which can cause that telogen effluvium. And then alopecia areata, also a very common type of hair loss that we see. But all 3 of these types of alopecia are all non-scarring and can all be corrected.
And that's great. That brings a lot of hope,
It does.
So, for our listeners, just know the most common is correctable. It's treatable. So if you're experiencing hair loss, seeking help would be definitely warranted.
For sure.
Because you see so many people that are very concerned about that hair loss.
Oh, yes.
And very distraught over it.
And that's for males and females.
Absolutely.
Alopecia, it does not just affect the psychological impact on females. It is very much present for males too.
Absolutely.
Even though there are some guys who have taken very good care of their heads and not like knocked them around as a kid and, bumped them and dented them and stuff like that, then they can go bald and look great. And there are some women who can pull that mess off too.
That's
now,
true.
I'm not one of those.
Same.
I'm not one of those. I know.
I don't even look good in a hat.
Right? I have a funky head.
Yeah.
I know I do. But it is like sometimes you just don't give yourself enough credit. But they'll fight it to the bitter end.
You're right.
Like they will fight it to the bitter end. You're like, dude, just let it go.
Right. But I think as a woman, that's so much easier to say. But I see so many men in the office that are truly bothered by their hair loss.
What would getting in the male side, and maybe women do it too, I don't know, but hair plugs, like pulling it from one place and putting it in another, is that because the damage is done and the hair's not growing back and that's your last ditch effort?
Typically.
Is that something that's like it actually takes off and does well, or does it just depend on the patient?
So I personally don't have experience with hair plugs. So I don't have very many patients that have gone that route. I think most men would be more likely to probably just adapt to the bald head lifestyle. But I have seen instances where patients have had success with that.
That's good.
Yeah.
So let's talk about treatment then. With those common causes, how would you approach treatment for both the scarring and then the non-scarring different types?
Yeah. So scarring, like I said, the main approach with that is how can we turn that problem off as fast as we can?
Yeah.
You're not going to bring the hair back. So in that instance, it's very important for me to set realistic and reasonable goals with my patients when we're looking at scarring hair loss, to let them know, we're looking at a situation that is not going to result in your hair coming back, but how can we stop this from getting worse?
Yeah.
So a lot of times that can be a combination of systemic steroids. So we'll do prednisone by mouth.
Sure.
We can do intralesional steroids where we're injecting the area where the hair loss is happening.
Okay.
And that can certainly stop it from happening and progressing further.
Okay.
It oftentimes is the kind of hair loss, though, that can be very cyclical. So they may notice that the hair is falling out and they're seeing more alopecia. You can turn it off and they may go a period of time and things are great, and then they start to notice that it's happening again.
Okay.
So it can sometimes be a more ongoing treatment where we're having to go back on steroids kind of off and on. So that would be the scarring type.
Okay.
So non-scarring, so something along the lines of androgenetic alopecia. minoxidil. That is typically the first thing that I go for. You can treat topically and you can also treat systemically.
Orally,
I love the oral treatment for the minoxidil. It works well.
You do 5 milligrams, 2.5?
I typically do 2.5, sometimes bump up to 5 if we need to. But I have tremendous results with my patients with that option.
That's good to know.
Yes.
Yeah.
And the oral version is a lot easier. So the topical, it's just, it can be irritating to the scalp. Compliance can be a problem.
Yeah.
So the pill version is a great way to go.
Well, and there was a new study recently that came out, a randomized controlled trial that looked at oral versus topical and showed compatibility with results. So that was very affirming,
Absolutely.
And then I've heard also that the topical can be kind of greasy, and so women are like, I want hair, but I don't want to have greasy,
I want
greasy
dirty hair.
look. I walk around with that. So
and then there's
that's
the
good to hear.
men's strength and the women's strength of topical minoxidil, which is crazy for me. So I typically recommend for all women, if you want to treat topically, go with the men's strength. There's no reason why we're having to treat with the lesser strength.
Okay. Yeah.
Hair loss is hair loss.
Hair loss.
Yeah.
Not gender specific.
That's right.
It's not testosterone.
Yeah. You don't need a tenth of the dose. Right.
Exactly. So I say go with the men's strength, treat it every single day topically if that's the choice. But like I said, the pill form works incredibly well. The only thing that I tell patients caution is in the very beginning, whether it's topical or systemically, it is extremely common to see an acceleration in hair loss in the beginning. So that can be very stressful for patients.
So it speeds up to slow down?
It does.
So
that's
exactly right.
Yeah.
And that's probably part of that cycle, the hair cycle in and of itself. But how long does it take to see a result generally with that?
I typically say 3 to 6 months.
Okay. Yeah.
So 3 to 6 months is a good point of time to measure.
Okay.
Yeah.
And then it's interesting how minoxidil came to be. I think that's an interesting story in and of itself, how they discovered, because it was a blood pressure medicine.
Right.
And then
Blood
they
flow.
discovered that these patients that were on it came in with just tons of hair.
Fabio hair.
In place that, and so they really looked at that for hair treatment. And so that's kind of how that came to be.
That is interesting.
Yeah.
The downside.
Yeah.
Increase in facial hair
That's
for
what
women.
I was going to say. Hair in
Son of a
places.
monkey's uncle. I swear to all things that make us feel better. Hair on the face.
I know.
Yeah.
And it's not everyone. It's not everyone that takes it.
Mm-hmm.
And in fact, I would say it's a very small percentage of my patients that I see.
But you have to say it. Is it one of those things?
I like to tell patients just because that can kind of be a surprise.
Sure. And you can do something about that, I mean, there's dermaplaning and
That's right.
electrolysis, that sort of thing.
Exactly.
Okay, so minoxidil is a great treatment. What are some other things that we would
Absolutely
use?
love Nutrafol.
Okay.
Nutrafol is a
Good to
phenomenal
hear.
supplement.
Yeah.
It works.
I have that question a lot.
It does work.
Patients do take it, but they are always wondering, is this going to help me?
It really
it's a pill,
does.
right?
Okay. It is. It's
like
a
a
capsule.
supplement.
Yep. It's a supplement. You do have to take it 4 times a day in the beginning.
Okay.
I typically say 4 times a day for the first 3 months, just to trigger that hair regrowth. Once hair is growing back, then I typically will tell patients, try to titrate down on the dose. See what that lowest dose is that you can go on to maintain.
I love that.
Yeah.
Yeah.
So it's effective. It
Okay.
works. I would say in upwards of 80% of patients that take it, they come back and they see positive results.
That's significant.
It is significant. And
That's
that is
significant.
accurate. That is for males and females.
That's great to hear.
Then. Does it do the same thing? Could it potentially show up somewhere else too?
It does not. No. So I don't see the facial
This is
hair.
a miracle drug.
It can be.
Like I am down.
Again, 3 to 6 months, would you say?
Yeah. 3 to 6 months. Now it's a little pricier because it is a supplement. It's not covered by insurance.
Yeah.
So
Right.
it does have a higher price point. But, again, it doesn't have to be a forever treatment for a lot of patients. Now, some they go on it and they do need to stay on it. But for the majority, they can start it and then they can find that lowest dose.
I love that. I love that you do that with your patients.
Absolutely.
I love that.
Why are we taking more than what we need?
Right?
Yeah.
Absolutely.
And then, okay, so minoxidil, Nutrafol. Tell us what else.
So spironolactone.
Yeah, that's what I was wondering if that was going to come up.
I love
So what
spironolactone.
dose do you start patients on for that?
So I would typically start at 100 milligrams once a day. It for me, it is one of my favorite things to prescribe. Outside of just hair loss, it's great for acne. So for females, adult female acne, I have better results with it than I do just about anything else systemically.
Wow.
No kidding.
Wow.
Yes.
That's awesome. And probably less side effects than a lot of other oral medications as well.
Yes. And it's a great alternative for patients that don't want to be on a birth control.
Right.
So it's a great hormone-free option.
Okay. Yeah. And so it thickens scalp hair. Mm-hmm. It also helps with unwanted facial hair to rid us of that. So it has a twofold purpose, I feel like.
It does.
And another 6-month probably result as well. So
Spironolactone, I would say it's closer to 3 to 6 months.
Okay.
Yeah.
Yeah. All
so
right.
you'll see something a little faster with the spironolactone?
Possibly.
Understood.
Yeah.
Yeah.
Certainly depends on the underlying condition.
Right.
Yeah.
And I read again on that your steady state needs to be about 80 milligrams to be able to get that result. So I like that you started 100, you know.
I like to start aggressively on the dose of spironolactone just so that we can see really quick positive results. It helps with compliance. And quite honestly, too, when it comes to hair loss, because it is such a stressful thing for patients to deal with, if we can start to see results quickly, that's to the advantage. And then you can start pulling back on that dose.
Okay.
Yeah. So I like to treat aggressively in the beginning with the dosage and then start to titrate down.
Yeah. And then any other meds you can think of that you like, or have you experimented much with finasteride or?
I have with some male patients. It can be effective. I tend to go with the other options first.
Yeah, just because the side effects
can be, yes.
What are the side effects?
It can cause depression.
It can cause depression. It can cause sexual dysfunction. That can be more permanent in nature too.
Oh, wow.
Yeah. So you have to be super careful and cautious.
Yeah.
You know, even with the dosing, starting small again and working your way up if needed.
Understood.
I typically will monitor a PSA on these patients that I do have on finasteride once a year.
Okay, that's good to know too. And we do that regularly with our male patients anyway. So then what about like non-traditional treatments? Have you experimented much with red light therapy or seen any results with that?
So red light therapy has gotten really popular really fast. As far as results that I've seen with patients, when it comes to hair loss, I haven't really seen a whole lot with that yet.
Yeah.
I do have a lot of patients, though, that are willing to experiment and try new options. So I do like topical treatments with a red light therapy. So if I'm treating a patient with topical spironolactone, for example, they can use a red light. You can use a red light therapy with it as well.
Okay.
So a lot of the compounding pharmacies offer that.
Okay, yeah. So how does the red light help the spironolactone?
So it can help to decrease inflammation.
Okay.
So I think that there's a lot more data to come out about red light therapy.
And what I've read about red light is that you have to really target that spot for a certain length of time for a certain frequency. So and what I've actually read about hair is daily. So that if you have access to a red light, like at home, there's home use red lights that you can purchase if they're the right frequency, then you've got to use that every day for a certain amount of time to get that result. So it's probably one of those things that we need more time to see and more consistent use to be able to see the result.
Compliance is a hard thing.
Oh, yeah.
Especially with topicals. It's just very difficult for patients to be compliant every single day. I would struggle.
Me.
I mean,
honestly.
well.
Easily forgettable.
Right? It is.
Yeah. We're all busy. We're working, have families.
Yeah.
We're doing a lot of other things to help our health. And so it's hard to add one more thing in.
It is.
And be consistent with it.
I try to keep the treatments too very simple, something that doesn't take a lot of time. I don't try to have a high expectation for patients of things that I know that I couldn't meet.
Right.
So I like to keep it very minimal when it comes to topicals for hair loss too.
That's great.
Yeah.
And then lastly, I'll ask you about PRP. Tell me what your thoughts are on that. Are you using any of that in your practice or?
We're not.
Okay.
We're currently not doing PRP.
All right.
I've seen mixed results with it.
Okay.
I think that there can
platelet-rich plasma.
Yes. I think it can be effective in some patients, but then I think in other patients, not so much. So I think that there is some degree of inconsistency with it.
Okay. And that would be dependent on multiple factors.
Yeah.
And it's pretty costly.
It is.
As well. Is it
is.
painful on the scalp?
No,
Really
I don't
numb
think
the
patients
scalp?
really complain much about the discomfort associated with it. And I think too, especially if you're seeing results with it, if there is any discomfort, that tends to...
Yeah. They're willing to go through the pain.
Exactly.
Yeah.
Sometimes beauty is pain.
I know.
Beauty is pain. So there are some cancer patients who are going through chemotherapy who use a cool cap to try to preserve their hair loss is there something, well, I don't know the science with it necessarily. Is that a effective treatment? Is that something that you would do outside of maybe that the chemotherapy treatment to then,
familiar with it.
To go, there's a
I've
friend of
seen that
mine
as
that's
well.
going through,
Yeah.
her daughter-in-law is going through it, and they're doing it, and it seems to be effective.
Yeah.
So I was just curious as to like what potentially is the effect of that's keeping her hair, from.
Yeah. I'm not sure the
out.
actual mechanism of that. I know they use similar cool packs for the extremities to prevent like neuropathy forming. So it may have something similar
along those
in
lines.
nature, I'm not exactly sure. Maybe constriction of the hair.
Vasoconstriction, yeah.
That would make sense.
Yeah. So let's move a little bit. That's great. I mean, that's so helpful. Our patients struggle with hair loss and we hear it all the time. And it's great to know that, we're not alone and that it's a complex issue.
It
and
is.
trying to tease out exactly what the root cause is can be difficult sometimes. Let me ask you one more question on that iron. I see that a lot as a cause. Do you see low iron levels as being a culprit?
Absolutely,
commonly?
yes.
Yeah.
Yes.
Yeah. I feel
And
like
I don't know that it even needs to be extremely low. I think that it can be low normal. And I've had some patients that have, realistically been within a normal range, what would be considered a normal range with their iron, but would be low for them.
Right.
And they do struggle with issues with hair. And then, they correct their iron levels and then hair is restored. So I have seen that with patients as well.
So how would you coach a patient to prevent hair loss? If someone came in and said, my mom lost a lot of hair, I'm just making up this story, but let's say my mom went, she lost a lot of hair as she aged, her hair thinned. How would I prevent that in myself? Is there a way to prevent it?
I think that in an instance of family history, so if you have a very strong family history of hair loss, treating it preventatively would come in the form of making sure things like supplements, Nutrafol, that would certainly be a good place to introduce that. But for a lot of patients, preventative treatment, that would be very difficult. I would say the supplements, making sure hair care practices, you're not using a lot of heat, you're not using a lot of chemical. I say that while my hair is straight.
I know. We were just talking about this.
I literally just hung my head. I'm like, so there's that.
So coloring, chemicals, different hair care practice. Those would be things that I would say if you were wanting to be preventative for hair loss or hair damage, that would certainly be a good starting point.
Okay. What about hydration for the hair? Is that helpful to prevent like dryness?
Hair mask? I think that can be very helpful.
Okay.
Using a heat protectant too. I think that's also a good idea.
Okay.
Especially when the heat protectant smells good.
I know. That's a little motivating, isn't it?
Exactly. Is there a difference between hair loss and lack of growth? Does that make sense what I'm saying? So you haven't necessarily lost a ton of it. It's just not growing.
So if it's not growing, that can be from a lot of different things too. So a lot of times that can be related to, heat damage. That can be from, unhealthy ends. That can be from hair splitting. That can be from an actual deformity of the hair shaft itself.
Okay. Interesting.
Yeah.
So is there a treatment that would the Nutrafol help that?
It can.
Okay.
Yeah. So it can help with overall hair quality.
Understood.
Yeah.
That's
as well
awesome.
as the hair growth.
That's all, especially when it doesn't put it on your face.
Yeah.
That too.
And so let's move into that.
Circling right back to that.
And in the medical world, we call that hirsutism.
Ugh.
So that's abnormal hair growth or unwanted hair growth in areas that we don't want it: face, chest, abdomen for women,
Lower back.
Shoulders and
above the lip, that sort of thing. So
shoulders for men.
yeah,
My husband's so mad. He's so mad. He's like, there is not a speck of it that'll grow on my head, but it'll grow like wildfire on my shoulders. And I'm like, dude, I don't know what to tell you.
Embrace it.
yeah, right.
At least you got it somewhere.
That's right. So what do we do? Or tell me kind of how you differentiate that in your practice.
Yeah.
For the causes, and then what do we do for those things, or what do you do for those things? Because I know what we kind of try. But.
Yeah. So in an instance of increased facial hair in a female, I start getting very interested in what are their hormone levels, what's the thyroid, is there a history of PCOS, metabolic syndrome, any testosterone use? So I would be curious about those variables. I would start likely with some blood work and go from there.
Okay.
Yeah.
And then what do you see as the best treatment for that?
It depends on the underlying cause.
Yeah.
So again, if there's a thyroid issue, that would certainly be the starting point. If there is, if there's a history of PCOS, then I would consider some sort of a hormonal treatment or even spironolactone. Spironolactone comes in for me when we're talking about increased facial hair, increased acne. That would be a great starting point.
Okay.
Birth control, also a great option for younger patients. But yeah, I think testosterone supplements too, while I think, that obviously there is a place for that. Increased facial hair is very common to see with that treatment.
Good
and
with
acne
the bad.
sometimes.
Yeah. Good
with the bad.
I know. And it's all about trying to find that delicate balance.
Absolutely.
You know, like in our world, finding where we bring patients a benefit from their testosterone without bringing them a side effect.
Right.
And everybody is different. Their threshold for that is different. So sometimes it is just trial and error to see, how do you respond to this medication? Do you have any side effects? And then we can do some things about those things if we're getting a benefit from the product.
Absolutely.
So, yeah. So this has been great, Emily.
Awesome.
What? Let me ask you a few more little derm questions because we've talked about hair. Let's talk just for a few minutes about skin.
Yes.
So what changes in our skin do we primarily see as we go through, let's say, perimenopause, menopause?
Yeah, I would have to say one of the common things that I see with patients and one of the common things that we talk about would be change of elasticity, change in hydration to the skin, decrease in hyaluronic acid production, decrease in collagen, all the things aimed at how can we stop that from happening? How can we slow that process? What can we do to fix that process? I love using topical hyaluronic acid on the skin. I love microneedling to stimulate that collagen. Chemical peeling, love that too. So I think that there are a lot of changes that happen to the skin, certainly as we age.
And at what age do we need to start thinking about these things usually?
The sooner the better.
12. 12.
I know.
My soon-to-be 13-year-old daughter, she's using all the products. So I would say the sooner the better.
Yeah,
Absolutely. I just had microderm needling microneedling all over my face with PRP.
Love that.
I did it on Thursday, so I'm good and peely right now.
It looks great.
Thank you.
Honestly.
I have molted for most of the weekend. But I'm like, out with the old, in with the new.
There you go.
And I feel like when you do that, you get such a glow.
Oh, girl.
You know, it's so glowing. Like you don't even really need a lot of makeup after you've done that.
That's the goal.
Yeah.
That is definitely the goal.
I love it.
Yeah.
So that's so helpful for our patients, men and women. So tell us, we're going to shift gears a little bit and tell us a little bit more about your practice, what you offer, how we can find you, some upcoming things for 2025 for your practice so that we can hear just more about the Derm Center.
Yeah. So we opened our doors in December of 2022 and we're a dermatology practice. We focus primarily on medical dermatology, but we have incorporated some cosmetic treatments along the way. We treat over 3,000 diseases of the skin, hair, and nails. And that's something that I think a lot of patients don't realize when they think about dermatology is that it goes beyond just the skin.
Yeah.
We're treating hair. We're also treating nail disorders. For 2025, we definitely are, growing. We're expanding. We have a new PA who's going to be starting with us in the next few months. So we're excited about that.
Yeah.
But yeah, we love what we do and we love educating our patients. We love being a part of their skin journey.
So medical dermatology, but also some aesthetics,
yes,
right?
Yes.
So tell us about that.
Yep. So we do cosmetic Botox.
Okay.
We also do chemical peeling and microneedling.
Awesome. I highly recommend.
That's right.
Yeah.
But we also do Botox for hyperhidrosis, so excessive sweating.
Yeah.
Typically covered by insurance, non-cosmetic. So that would fall under the medical treatments that we offer, all of which very effective.
Great.
Yeah.
Well,
Where are you?
Yeah.
So we're located on 4th Street, right next to the Blood Assurance Building in University Tower.
It's so easy to get into and out of.
I know,
It's
exactly.
wonderful.
Easy parking.
Yeah. Easy parking.
Walk right in.
Beautiful office.
Thank you.
So if anyone needs a medical dermatology provider, I would definitely recommend Emily and her team. She has personally taken care of me and my family, Mandy, I think, as well.
Yep.
And so her expertise is definitely respected in the community. And we just are thrilled you've been with us today.
Thank you so much for having me.
You've taught me some things. And
good.
so I can take that back to my own practice. I hope that our listeners have learned a few things. Anything else you want to add, Mandy?
No, I just thank you so much for being here and taking care of me. And you've actually taken care of my bald-headed husband. So, we didn't quite hit in the hair zone, but
Other more pressing issues, probably.
More pressing issues. Yeah. But thank you so much for coming and hanging out with us today.
Absolutely. Thank you so much for having me.
Until next time.
Until
sister.
next time.
You've been listening to another episode of Optimized Health with Josh Porter and Mandy Livingston. For more information and past shows, go to our website, optimizehealthnow.com. Thank you for listening.